Good afternoon, everybody. I'm Fabio Akimascu. Welcome to our latest conference in the Implementation Science for Innovation and Discovery series. I will do some introductory slides here, and then I will introduce our speaker. So I thought I would start out with the public health challenge that we have, and we have touched on this in the previous sessions. We have more than 10,000 diseases, and less than 5%, 5.5% have treatments and cures currently. And the time from early development to medicine cabinet or to pharmacy takes on average 10 to 15 years. So that's a long time. And only 9 out of 10 trials end up in successful results. So then the candidates for promising therapies are making into clinical practice. The next few slides I borrowed from NCATS, who set up, it's our funding agency for clinical and translational science institutes called National Center for Advancing Translational Sciences. Their audacious goals for the next 5 years is to actually make it from 5% to up to 25% of diseases to have at least treatments in development, to be addressing all subgroups of our populations, and to actually develop these therapeutic avenues 2 times faster. So, make it 7 to 10 years if you want, on average, from early development all the way to the cabinets. I thought I would list here also the scientific and operational approaches to advanced translational science that NCATS has listed, and you will hear more and more about this. This is the object of our investigation in CTSI. It's about translational science, which is defined as a field or domain, a discipline that generates scientific and operational innovations that overcome long-standing challenges across the translation and research pipeline. And I thought this was another important approach from their strategic slides, going from T0, from preclinical basic research, all the way to T5, which is communities and policy development. This is the translational pipeline. And on purpose, the NCATS has shown there that sometimes we're dealing with bottlenecks, sometimes we're dealing with strictures in this pipeline, and that can create this type of turbulent flow, if you want. So they clearly specify that bottlenecks can be represented by administrative burdens for study startups, insufficient tools and technologies that can predict toxicity or efficacy of new therapeutic avenues, low enrollment, which we've been struggling for years, and lack of diversity of subjects participating in clinical trials, and sometimes lack of communication and the databases that do not necessarily become available to investigators, and there's no cross of information from one side to the other one. And what NCATS is proposing to create different solutions to these bottlenecks, such as streamlining business models and the regulatory processes for these, create platform-based approaches that will actually go to study multiple studies and looking at multiple diseases at a time instead of one specific condition, resort to innovative and adaptive clinical trial designs, and use large-scale data interoperability and integration. I would contend that actually this is still a pretty linear process. So despite the fact that we're creating this type of laminar flow, it's still very linear. And I wrote an editorial a few years back discussing how we shouldn't be working with these T0 to T4 or now to T5 silos in a linear fashion, but maybe create architectures that will actually provide better flow of information and efficiencies. Also on the radar for strategic planning from the NCATS point of view, they clearly point out that data science opportunities may be one avenue to streamline these processes. Looking at operational excellence, how do we develop that? looking at education and training tools to create the workforce of translational science. And then, of course, creating collaborations, team science across multiple disciplines, which goes together with the global opportunities on this slide. Of course, is going to be a development of new policies that will be more conducive to successful translation. We've been discussing for more than a decade about how the designs of the clinical trials have to be patient-centric and engaging patients in the design of the trials. And of course, once we conduct them with engagement, continue, and then of course the dissemination part. I would remind you from the previous talks that we discussed about theories, frameworks, and models. Some people call these constructs of implementation and dissemination science. I have touched during last talk about the EPIS framework that was developed by Doug Aarons, that goes from exploration, preparation, implementation, and sustainment. And I chose this framework because it's one of the important frameworks that is used in the healthcare, but also because you may see some bridges between this framework and the framework that will be presented today. So the authors that refined this model, and then it's been used in more than 50 randomized studies and then applications in healthcare, goes from innovation factors that are at the center of the model, and then bridging factors with communities around academic partnerships, and of course payers, purveyors, and other intermediaries. But then, of course, do not forget about the context, outer context and inner context, and you see how leadership, organizational characteristics, quality and fidelity of different evidence-based interventions play a role. So I thought it would be just a teaser. And let me introduce you now our speaker, Professor George Easton from Emory University in Goizueta Business School. It's our pleasure to have him tonight and give another exciting talk. He's going to be talking to us about the use of Baldrige model for healthcare quality in implementation science. So I will stop sharing here. Welcome, Professor Easton. You are muted still. You are still muted, Professor Easton. We cannot hear you.
All right, maybe that works.
That works.
Yes.
Welcome.
All right, so what I'm going to talk about today is the Baldrige model of healthcare quality. And I'm just going to go ahead and jump right into to the key things that I want to say. So, you know, as an outsider looking in on what's going on, there are major entities that are playing various roles in patient science. Obviously, NIH and other funding agencies or entities are very interested in more impact on practice from their funded research. Then another group of entities are the healthcare organizations, and I've listed here some of the things that come to my mind as to what they care about. Obviously, they care about revenue, reputation, and outcomes. And you know, this is very limited here, so there's probably a lot of more that could go in here. And then there are centers and institutes, and they are interested oftentimes in their role is really to provide expertise or to provide to foster the implementation. And they're interested in funding and then research papers, and then of course actually driving the implementation. And there is an underlying theme through all of this that the ultimate goal is to impact in a positive way patient outcomes. Then there are the individual healthcare providers that are mostly within these organizations. And they have a lot of things they're interested in as well, but certainly the outcomes for their patients are things that they care about. And I put here that they have an interest in the status quo because in some sense that's what they're used to doing. And then there are people and teams that are doing implementation science research. Okay, and so of course these people are interested in research papers and funding and so on, and I expect that various members of this audience are associated with one or more of these entities. Now, what I wanted to begin by saying is that the Baldrige Award criteria are operating at the level of healthcare organizations. Okay, and so, you know, as we talk about this framework, it is a framework for operational excellence for healthcare organizations, sort of broadly defined. Now, I want to, I've probably got too much in my slides. That's a bad habit that I have. So I wanted to get to what I think is an absolute key takeaway from what I'm trying to present today. And that is, according to the Baldrige model, to effectively move innovations from research to practice, you need a well-developed process to scan for, prioritize, potentially test, and implement the innovations ultimately in I've used the word work processes here, but in the actual treatment and patient processes. And as I'm reading my slide, it doesn't come across quite as powerfully as I'd like it to, but this is within those healthcare organizations. Oh, it did. It's the next bullet. Okay, so to be effective, this occurs at the healthcare organization level. Okay, this is really what one of the things that this Baldrige model that we're going to be getting into is really saying, and it's saying that based on what it's focused on. It's focused on the healthcare organizations. Now, for these implementation processes, you know, going from basically an innovation idea into the actual treatment processes, requires, again, at the level of the healthcare organization, leadership and strategic intent. And it requires that because organizational change is hard, and implementing clear processes for driving innovation into the work processes of the organization is a kind of organizational change in itself. And then the actual things that you implement involve changes in processes and in care pathways and so on, and organizational change is hard. So I guess I'll just quickly sort of back up. As I look at implementation science papers, primarily from the journal Implementation Science, where the focus is very muddy. Okay, so I thought I'd just clarify at least what the Baldrige is saying. Okay, I have a couple of actually other things here in my key takeaway. Other entities can help, but I think the Baldrige model basically says that without these well-developed processes within these healthcare organizations, implementation is going to be haphazard, inconsistent, consisting of inconsistent one-offs. And frankly, that's what I think much of the implementation science papers that I've looked at, I would really classify as they're inconsistent sort of one-offs. They're talking about implementing one particular sort of innovation or change, and oftentimes one or maybe a couple of organizations, and it's not at the level of abstraction that actually, you know, Tavi was presenting in his introduction of an overarching sort of framework within the organization for making this happen. So there is a very big difference between the following, which is to foster, incentivize, support, encourage implementation of innovations, and an organization having very specific goals for implementation of innovations, and so we're talking about specific goals. So in this next planning cycle, we're going to look at 3 areas of healthcare, determine what is the highest priority innovation to try to drive into our system, and so on. The more specific these goals are, the more likely they are to actually happen, assuming that there is both leadership support and the resource support to make it happen. So what I see over and over again in leadership is that they want to support some kind of idea or some kind of improvement. And this is common in industry. Healthcare is really not, in a way, not that different, because regular industry has the issue of new product development and of scanning for innovations and implementing them. But until the leadership gets specific, then you're not really likely to make much progress. Okay, and I think these couple of slides are really sort of the key takeaway from all of this. So now I'm going to tell you about what the Baldrige Award is. The Baldrige Award is a presidential award for performance excellence. It's based on an assessment framework, which is what we're going to be talking about, which consists of 7 major categories. And the categories are leadership, strategy, customers, knowledge management, workforce, operations, and results. I'll be talking about these in more detail. And the framework is developed around a core set of values and concepts, which include things such as valuing employees, a focus on customers, and in this case, patients, and a systems perspective, which essentially means a focus on developing processes. And the Baldrige Award is administered by the National Institutes of Standards and Technology, and it is a public-private partnership, which means that except for the administrative support from NIST, it is funded by a private foundation. So this diagram I have pulled out of the 2023-2024 Baldrige Excellence Framework for Healthcare, and I'm not going to spend a lot of time on this right now, but at its core is the systems perspective. See if I can get my mouse cursor over there. And then around that are these values such as ethics and transparency, societal contributions and community health, agility and resilience, and so on. Valuing people is a very important one. So these underlying values then should be seen throughout the 7 major categories in this framework, which again are leadership, strategy, knowledge management, customers, workforce, and operations. This slide, and I hope that either the slides or a PDF of them are distributed, contains basically all of the key links that you would need to get drill down further on what the Baldrige Award Framework is. The top level website is given in the first link. The Baldrige criteria are a product that they sell, so I wasn't able to distribute that with my slides, but it's not expensive. You can get a copy of the PDF for $12. And then they have a variety of tools that are useful for helping organizations understand this. They have something called the Baldrige Excellence Builder, which is kind of a self-assessment tool, and it's free. And then they have a training case study, which is used to train the people that actually do the evaluations, together with an evaluation of that case study. And we're going to be looking at some of this in a little bit. So I want to give you a brief history of how all of this came to be. And I'm going to go through this very quickly because I don't want it to use up too much time here. But beginning in the mid-1970s throughout the decade of the 1980s, U.S. industry was being severely challenged by foreign competition, and most notably and very specifically from Japan. And so many U.S. companies lost a lot of market share, or the businesses failed. And there were a remarkable number of industries that the United States just basically lost, which one of the leading examples of that was machine tools. Now, there are a lot of different ways that you can have competitive pressure, but it was generally perceived at that time that much of this competitive pressure was a result of product quality. And that is to say that many of the products that were made in the US were simply inferior to those of the Japanese competitors in terms of things like certainly reliability, for example, but oftentimes in terms of even the performance characteristics of the products. Now, not unsurprisingly, U.S. companies started to react to this, and they started to try to figure out exactly what it was that the Japanese companies were doing that allowed them to achieve the superior quality and reliability. And what tended to happen in the early days is that the U.S. companies oftentimes fixated on a relatively superficial characteristic of the Japanese system. So, for example, around 1980, quite a few companies in the United States had noticed that Japanese companies were using teams of frontline workers that were focused on quality improvement. And in Japanese management, they call these quality control circles. And so this led to a major quality circle fad in the US around 1980, which for the most part completely failed, in large part because the US companies didn't really see the full context of the system in which these quality control circles existed. Another example of this was just-in-time manufacturing, which kind of became a fad in the mid-1980s, and it had mixed results. Now, in this process that many U.S. companies were going through and the economy was going through, some executives and observers realized that there was much more to this Japanese management system than one or two characteristics like quality control circles or just-in-time. And what they discovered when they drilled down on this was that there was a well-developed quality management system that had developed in Japan, and it had been developing in Japan since the end of World War II, so it wasn't remotely new, that went by the name of total quality control. And this system of total quality control, which was implemented in various companies and always modified and customized to those companies, but there was a national organization that focused on the development of total quality control, promoting it, training and consulting with companies, called the Union of Japanese Scientists and Engineers, and I've provided a link to their website in case you're interested. There's actually a lot of great material on that website. So starting in the mid-1980s and really picking up steam around 1990, quite a few leading U.S. companies began trying to implement quality management systems that are similar to Japanese TQC. So examples that came to my mind were, because I was involved with these companies at the time, were Ford, Whirlpool, Xerox, Federal Express, and there were many, many others. Allied Signal was another major company at that time. Now, it was recognized by pretty much everybody that you couldn't just take the Japanese system and just bring it over here without changes. So the efforts to take this system and implement it in the US became known as total quality management, using a different name because it was clear that the systems were going to have to be different. And in subsequent years, so for around the mid-1990s, total quality management morphed into Six Sigma, which many of you may have heard of, and Lean as two parallel things at that time. And then around 2000, Lean and Six Sigma really merged. And as many of you know, there has fairly recently been significant efforts in a lot of healthcare organizations to implement Lean systems. Now, the one other thing I want to mention in this brief history is that the Japanese developed their systems starting after World War II with the help of one very notable quality guru, who's W. Edwards Deming, but also another early quality guru by the name of Joseph Juran. So this expertise and these gurus, and they were at guru level in Japan, were largely ignored in the US really until the mid to late 1980s. Now, I've given you sort of the history of how these ideas really sort of developed in the United States. But the key thing, or a key thing that led to the development of the Baldrige National Quality Award was the fact that Japan had a National Quality Award for excellence in the system of TQC, which was called the Deming Prize, named after W. Edwards Deming. And it was administered and awarded by the Union of Japanese Scientists and Engineers, this sort of nationally endorsed organization. Now, because of the observation and the studying of the Japanese system, many U.S. quality experts felt that the U.S. really needed a national award that was similar to the Deming Prize. And in addition, at that time, the continuing competitive pressure on the U.S. economy and, as always, the resultant job losses made this whole set of issues an important political issue. Now, the actual creation of the award was kind of, in a way, kind of random, because in July of 1987, the Secretary of Commerce, who was Malcolm Baldrige, so that was his name, was killed in a rodeo accident. And he had been very well liked by both Republicans and Democrats, and that, in fact, was even possible at that time, although I suspect it's not possible now. But anyway, but I do not actually know. I was beginning my career in this whole area around that time, but I do not actually know who came up with the idea, but those who were trying to promote creation of a National Quality Award came up with the idea of using the award to honor Malcolm Baldrige. And because of his popularity, and because of the fact that this was requiring Congress to allocate no money, since it was this public-private partnership, the law creating the award passed Congress as the Malcolm Baldrige National Quality Award in 1987. So the first awards were given in 1988. Award applicants at that time could apply in one of three categories: manufacturing, service, and small business. In 1999, roughly a decade later, separate categories were created for healthcare and education organizations, although there had been quite a few healthcare and education organizations that had applied in the years before there were separate categories. And then in 2007, another category was added for nonprofit or government organizations. And one of the last things I want to say about this, I don't know if I have more bullets, is in the late 1980s through about the mid 1990s, it's really hard to overstate how prestigious this award was. It was a huge deal in the United States. It got coverage in the popular press, and as I say, it was just a big deal. Now, its status, after about the mid 1990s, began to sort of trail off, which I think is the normal life cycle of everything. But it was a big deal at the time. Now, I've got a couple of slides here that I want to use to emphasize how significant what Japanese management had succeeded in achieving. So in 1990, there were 3 U.S. car companies, GM, Ford, and Chrysler. In 1990, Japan, there were, how many do I have here? 7, okay, car manufacturers in a country that's roughly half our size and population. And many of these brands, in 1990 would have been had as high a stature as Ford, GM, and Chrysler. So Toyota, Honda, Nissan, and so on. I'll say one other thing here. These top brands, Toyota, Honda, Nissan, did something that every business school professor would have told you they couldn't have done at that time. And that was to enter the mature market of luxury cars. So Toyota's luxury brand is Lexus, Nissan's luxury brand is Infiniti, and Honda's luxury brand is Acura. But they entered those markets in the late 1980s, when in fact, of course, luxury cars in the US were a mature market. And they were not only competing against US manufacturers, but also European manufacturers like Mercedes. Now, I guess in framing this before we get into the criteria, little has changed, okay? And in fact, since this competitor pressure was happening in the early 1990s, it's more like we've gotten used to the fact that that we have these competitiveness problems. So I've got a picture here that many of you, I'm sure, are already aware of. This is looking at the sources of drugs in the U.S. And so this is looking at active APIs, active pharmaceutical ingredients, according to the DMFs, which are Drug Masters files. And at present, 48% of those are coming from India, 13% from China, 10% from the US, 22% from Europe, and 7% from the rest of the world. And again, I don't need to go into this in depth, but certainly the COVID pandemic highlighted our dependency on foreign sources for not only drugs, but also for basic medical equipment like masks and so on. But you all are very familiar with exactly that. So before I get into actually talking about the criteria, I thought I'd tell you a little bit about my expertise. I became involved in this very early in my career and very early in the award process. I was part of the team of people that evaluated the applications and went to site visits in '89 and 1990. And I was a senior examiner. They have various ranks in '91 and '92, and led 2 on-site evaluations of companies. So in my examiner years of '89 and '90, I did participate in a site visit to Federal Express, and they did in fact win the award that year. In '91 and '92, the companies that I led the site visits to did not have sufficiently well-developed systems to win the award. I was involved in evaluating written applications for 22 companies in those 4 years, and they were evenly split between manufacturing and service companies. And just to give you some idea of the scope of a site visit, generally a team that goes and looks at a reasonably large company is going to consist of 7 examiners, one of whom will be the team leader, and that site will last about 5 days, and the team will typically come into contact, depending on the size of the company, with 500 plus employees of that company. Okay, so the Baldrige Healthcare Framework. There are 7 categories for evaluation, as I said before. They are leadership, strategy, customers, measurement, analysis, and knowledge management, the workforce, operations, and results. And I think the way that I wanted to jump into this was to spend a little bit of time here actually looking at 1 or 2 items in the criteria that connects most closely with the idea of implementation science. So the second category is strategy development. And these 6 items, let me just back up to that. 6 of these categories, leadership to operations, are considered to be process categories in that what they are asking an applicant company to do, and I haven't actually said that, but let me just back up and say that companies apply for this award by submitting a written application. The very first part of the application is called the company profile, and it basically describes, you know, what the business that the company is in and what the context is for that business. So, the key idea is that an examiner can read through this company profile section and have a reasonably good idea of what this organization is doing and what the key issues for that organization are. The rest of the company's application responds specifically to essentially questions, criteria in these 7 categories. And then, as I said before, 6 of these categories are classified as process categories. So they're asking for descriptions of how the organization you know, does these activities. The last one is results, and it's pretty much self-explanatory. It's looking for data and sort of hard results. Okay, so what do these things look like? So I've pulled out the first part of item 2.1, which is strategy development, and the overarching question here is how do you develop your strategy? And so sub-item 1 here is the strategic planning process. How do you conduct your strategic planning? What are your short and longer term planning horizons? How does your strategic planning process address the potential need for change, prioritization of change initiatives, and organizational agility and resilience? Item 2 talks about strategy considerations. How do you collect and analyze the relevant data and develop information for use in your strategic planning process? And how do you consider the following key elements and risks as a part of your strategy? So I've put an arrow here by the piece of this that most closely is linked to the idea of implementation science, and that is how innovations and technological changes affecting your healthcare services operations or markets, how those are identified as part of this planning process. The criteria are detailed, and you know, one can learn a lot by really drilling down on a lot of this stuff. It can be tedious. You have to develop sort of stamina for it, truthfully. And I want to just keep things at a relatively superficial level for this talk. Just to give you an idea of what a complete item looks like, I have the rest of the item here on the next slide. All of this is taken out of the criteria. So where I have the red arrow is another issue that relates to the idea of moving innovation into your regular work processes. So it's how do you identify strategic opportunities and stimulate innovation? How do you decide which strategic opportunities and intelligent risks to pursue? And so on. So what do you decide to outsource or not? That's the next item. And then B here is your strategic objectives. Okay, so with each one of these items, there are a series of notes. And if you are to go and actually look at and use the Baldrige criteria, there is oftentimes a great deal of wisdom in the notes. Okay, so I would encourage you to consider looking at those. What I have put in the red box here is a statement that basically says that this whole issue of service design strategies and in the context of the Baldrige Award, if you start talking about the service design and improvement strategies and methods for moving innovation into those, it is very similar to many of the ideas that are around implementation science. But the key point here is that if I'm trying to map implementation science onto the Baldrige criteria, it actually lives in a variety of different places. So every one of these items is evaluated on 4 dimensions. And this slide is actually a very useful framework for thinking about implementing processes. The first dimension is approach. So is the approach that the company is taking appropriate for what they're trying to do, or the organization is taking? Is it well defined, and does it, on its surface at least, appear to be effective? So basically, very simply, is the approach good? The second dimension here is deployment. And deployment of these approaches has to do with whether this approach is systematically and consistently implemented in all of the appropriate areas in the organization. Okay, and is it supported by the appropriate systems that you would need to achieve that, such as training, measurement, is it understood by all relevant employees, and so on. So in almost all organizations of any size, you get a phenomenon of pockets of excellence, where they're doing fantastic things in various areas. What distinguishes a lot of those organizations from ones that are more mature and closer to world class is that in a better company, the pockets aren't so much pockets. Okay, best practices that are determined either externally or within the organization are deployed broadly in appropriate areas across the organization. Item number 3 here, they now have called learning. What it was originally was improvement, and what one would be looking for in evaluating an application is whether or not there were multiple cycles of systematic improvement that had been done or conducted on this particular aspect of the process. So improvement might include adoption of best practices or innovations, might involve some benchmarking, but it would certainly involve, and I really should have had this in the bullet here, application of a systematic improvement process. The last dimension here is integration, and integration is really recognizing the fact that in many systems, there are many problems occur across handoffs and organizational boundaries. So part of the evaluation of these process items are these boundary issues addressed? Does this process interface well with other parts of the organizational units? And another aspect of this is the process and what's going on aligned with the actual strategy of the organization. So we're going to look now at a example of a response from the case study that I've also given you the link. And the applications are frequently full of acronyms. And I'm going to just sort of jump into the middle of this case study and show you the kind of responses that you might get, and then the evaluation. It turns out that in 2022, the case study actually for the entire Baldrige Award process was a healthcare case study, and it was a fictitious. These case studies are always fictitious, but they're always kind of based in truth as well. But a fictitious large regional healthcare system, which is called the Kopensberg Regional Health System. So let me just get out of this and now pull up I need to pull up the PDF file that I also provided and should be distributed. And we're going to look at this. It may be a little bit small for you all to see, and I'm not going to drill down too much on the details here. But in this response, a strategic planning process (SPP) has been outlined here that consists of 16 steps. Okay, the first part here is about collecting information for this process. The second part is about developing goals, objectives, and action plans. The third part is about how the deployment of the plan is going to be monitored and reviewed. And the fourth part here, the fourth part here is really about, how is this process going to be modified and improved. Now, an examiner reading this application is going to be looking for evidence that there is a well-defined process. And this, again, is true for all of these process items. And so, and we're not going to look at this in detail because it might become a bit mind-numbing, but what we're looking for are things that talk about when the planning process occurs, about how often. So they're talking here in early part about a change in how they did this from a triennial event to an annual event. If we go up here in the rest of the discussion, there's a discussion of a community health assessment. Okay, and there's a lot of verbiage in here, which, if you're reading this as an examiner, you sort of think might be kind of, just BS, truthfully. But they begin to start talking here about various specific artifacts. So this pestle, I don't remember what it is, I'll have to look it up, is political, economic, social, technological, legal, environmental, and workforce. So this is a tool that they have that provides a framework for doing the strategic planning. Actually, this CHNA, not the other thing, is the Community Health Needs Assessment is what that is. So there's another tool there. And so as an examiner would read and try to evaluate this, you'd be trying to make sure that there is a clear and well-defined process, that there is enough information given that you can assess whether or not this process is actually deployed and potentially deployed, everywhere that it's supposed to be. You're going to look for evidence of cycles of improvement, which is really discussion around changes that have been made, and ideally you're going to be looking for evidence that the improvement is in fact systematic. Okay, and that's very important. All right, and so so you get some idea of the verbiage that might surround it. Now I'm going to very quickly look at the feedback report for this item. And we'll just talk through this pretty quickly, not in too much detail. So the overall finding on this first item, strategy development, is that they have a well-deployed and systematic approach to strategic planning that has benefited from cycles of learning and improvement. And part of the process of writing the evaluation is that you're going to identify the strengths, okay, and then provide evidence of what supports them. So what this feedback report has done is then provide the evidence in this application to indicate that this planning approach is in fact systematic. So they recognize the figure that they have this 4-stage approach, which is fundamentally based on the problem-solving process, which is plan, do, check, act. They indicate who is involved ELT is the executive leadership teams, and and SLTs are senior leadership teams, I believe. They talk specifically about the planning horizons and so on. Okay. Now, the next finding is that this healthcare system has a systematic approach to collect and analyze data and to develop information for its strategic planning process. And so this is going to note that the first three stages of this involve data collection and so on. Incidentally, one verifies these things in the site visit. Okay, the way you actually end up doing the site visit is there's an enormous amount of prep work based on the documentation that the company has given you, where you try to identify the things that you absolutely must confirm if this company is going to be a winner, things that would absolutely torpedo their chances, and then significant open questions. So when you go on the site visit, it is a very intense process where you're trying to drill down and verify what's really important and has to be there, things that would sort of damage the whole thing in a significant way, and then open questions, and oftentimes many open questions. So I did want to go down here when we get to opportunities for improvement. The finding in the feedback report is it is unclear how the organization's strategy development process stimulates innovation. And in my reading of what they had said, that is absolutely right. I skipped over these words pretty quickly, so you wouldn't have had a chance to read them. But one of the things they claimed early on in the discussion of this strategic planning process is that they were using applications by Baldrige Award recipients to try to develop ideas for improving this strategic planning process. And in fact, from one of those recipients, they had taken a Shark Tank program, which was sort of based obviously on the television show. But the Shark Tank program was a program developed whereby people could present ideas that for analysis, essentially, that they wanted to be part of the plans. This Shark Tank program, incidentally, when I read this, I thought was kind of an innovative idea. I'm not sure I would have listed it quite so directly as an opportunity for improvement, but it is absolutely clear that there was nothing in the discussion of the strategic planning process that was specifically about driving innovation into the processes. Okay, so I guess we'll save questions for the end here, but I've already showed you the case studies. Now, I want to add a little bit of commentary from my point of view here. I am not impressed by ever-increasing bureaucracy. Okay, and a legitimate concern about frameworks like the Baldrige criteria is that they may drive the creation of bureaucracy in a way which is really not helpful. And so I wanted to just say a couple of things about that. How do you avoid this oppressive level of bureaucracy? Well, the first thing is that and I looked for this and did it time for in applications, whether or not there was clear prioritization and focus. Okay, most organizations can only implement a few changes, like 2 or 3 significant changes in the planning cycle. And so I believe that the Pareto principle always applies. And what the Pareto principle says is that there will be a small number of things that are critically important. Other ways you avoid developing bureaucracy is to have the improvement system relentlessly focused on cycle time reduction. It's very hard to be fast and bureaucratic at the same time. And then also specific methods in the improvement process of process simplification. And finally, customer focus. I mean, what happens in bureaucratic organizations is that bureaucracy actually interferes with serving the patients in this case. But structure is required, which means processes are required at some level of definition, or things simply do not happen in a systematic and repeatable way, or they do not happen perhaps at all. And, you know, I'll share with you what I've learned, and that is that the structure an organization needs at the current time is always slightly more structured than is natural and comfortable for that organization. However, if the structure becomes too constraining in a sense for the development of that organization, then usually the organization will rebel against it. So this whole issue of creating a really effective processes is firstly something that evolves over time, because as the organization matures, the processes can typically become more rigorously defined. But at any point in time, you're trying to find this sweet spot where the processes are structured enough, but not so much that you get a rebellion. Okay, I'm going to jump to the next major item that specifically involves how innovation is being driven into the processes of a healthcare organization. And this is in item 6.1, which is the work processes, how you design, manage, and improve your key healthcare services and work processes. The item here the sub-items here that most closely relate to innovation science and implementing innovations is service design. How do you design your healthcare services to meet key requirements, including how you incorporate new technology, innovations, organizational knowledge, and evidence-based medicine, and so on. Okay, so that's really talking here about moving innovations into practice. And then item 4 here talks about your key work processes and how you incorporate new technology or other innovations into those. The healthcare criteria are based on the general Baldrige criteria with a lot of rewording to be more consistent with healthcare. I actually find this a little bit confusing here, or confusing wouldn't say is quite the right word, but in a manufacturing company, this would be product design and this would be production process design. And I think they've tried to keep a distinction here, which is a little bit artificial, because in a service business like healthcare, the service and the process are oftentimes go hand in hand, not always. Okay, so I've given you a little bit of flavor of what the Baldrige criteria look like and what a response to at least one item would look like, and then the feedback. As I had indicated early on when we looked at that diagram that was sort of the summary of the Baldrige Framework, it's based on these core values. And I have the core values listed here, and then the second sentence, and I intended to change the color here so it was more obvious. The first part of each of these responses, like systems perspective, is the core value from the Baldrige. And the second sentences here are my commentary on that. So systems perspective really is talking about the IDIV processes, okay? And so there is one, everyone should understand that central to the notion of the Baldrige Framework, and pretty much any of these quality frameworks, is in fact this notion of structuring work and of processes. Visionary leadership. So this means clarity about mission, vision, and values. Okay, and in fact, leadership itself ought to be framed as a process. It ought to be very clear of who does what when, what messages they're trying to convey, what they support through, showing up, and so on. Patient-focused excellence is clearly talking about clarity about customers. Okay, and I'm very well aware that in healthcare, patients have characteristics of customers. They also have characteristics of raw materials. They are frequently unable to judge the quality of what was done to them, of the procedures. They can judge how they feel about the outcomes, but that's a different thing. Incidentally, that is a characteristic of healthcare, but that's a characteristic of many other industries as well, is that the customer is not really able to judge the process of the product. Valuing people. The human part of these work processes is extremely important in the context of the Baldrige criteria. And also, it is in Japanese management as well. And in fact, that was one of really the differences between sort of typical Western management and Japanese management going back to 1980 or so. So people are absolutely key. Training is really important, but also are issues around safety, ergonomics, job satisfaction, and so on. Another of the Baldrige core values are agility and speed. And speed has to do with short cycles. So really a part of this notion of process is to try to conceptualize all work is occurring in cycles. And speed is short cycles. And agility is really the ability to change course. And your ability to be agile is very much tied to how fast your cycles are. Because typically after you execute a cycle, you have an opportunity to change. Organizational learning, one of the values, is about systematic improvement, about using improvement processes like Plan, Do, Check, Act was sort of a traditional one. In Six Sigma, there's one called DMAIC. It really doesn't matter which one you use, but that the improvement activity is structured. And then A3 here is a problem-solving process that's part of the Toyota production system. And A3 does, in fact, refer to the paper size A3, but that's because they always did this on that size paper. Focus on success and innovation, so new product and service development, situational awareness, effective external surveillance, effective planning. Management by facts, the idea that decisions need to be made based on data. Societal contributions and community health. This is to say that what is done has to create real value rather than taking value from some people and giving it to others. Okay, and that also is a fundamental idea in Japanese management from the early days. Ethics and transparency, and then delivering value and results. And so the results must be on metrics, data, and credible evidence. So I'm going to sort of skip over this. There are a couple of other things I want to say here before I wrap up. Even at the top level of these 7 categories, leadership, strategy, customers, and so on, the Baldrige framework is kind of useful because you can go into any process. So for example, sort of an implementation or translation process that's innovations and trying to test them in practice and move them into actual regular protocols for care. You can look at something like that, a single process, and ask questions around this Baldrige framework. So, for example, who is leading that process? So in this case, I've framed it around trying to move innovations into practice. So who is leading the identification and implementation of innovations? How are you doing that? strategy, the questions that would come up around a specific process, like trying to move innovation from, into an organization, is how are we planning to use the innovation implementation process? What are we going to do with it? Okay, how are we planning to improve it? Keep it aligned with the overall strategy. In any single process, it's very useful to ask who the customers are. Who are the internal customers of the process, which typically would refer to other employees, other of your own people that are receiving the output of this process. Who are the external customers of the process, which of course in healthcare would generally be patients. How do you assess the requirements of these groups? Is this process measured appropriately? How do we systematically improve it? With respect to workforce issues around this process, are the employees appropriately trained? Is there appropriate performance appraisal, reward and recognition, safety, ergonomics, job satisfaction? In the operations category, is the process well-defined and appropriately deployed and systematically improved? Does it seamlessly integrate with other processes? And then finally, what are the performance results? So performance results, what are the trends in performance in comparison to benchmarks? What are the results of the implementation of the intervention? How have they changed the level of performance in those interventions, that is, in comparison to the benchmarks? And the real question around this is this process world-class? And does the organization, do we even know what it means to be world-class in this process? And if you don't know, then you need to figure it out. So you have some idea of what the vision that you're moving towards is. If the process isn't world-class, why isn't it? And how do we make some, and by why is it, what are the gaps? Okay, and how do we make some progress, rather, that should be, word should be progress, towards moving in the direction of world-class? Okay, when you're evaluating metrics, I just wanted to talk about this as the last thing. The first thing that you're going to look at is the set of metrics that give you a good picture of what's going on. And then the next two bullets are extremely important. Do you have evidence of improvement trends relating to your cycles of improvement? And in data to establish a trend, you typically need a very, very minimum of at least 5 points and presumably more than 7. Okay, and I am a statistician, so I'd actually like more than that. But the point is, you don't establish a trend by 2 consecutive quarterly results or 3. And then the next thing around results has to do with levels and comparison. And a world-class or a really top-level company will be looking at the performance of their key processes, able to tell you how that performance relates to both world-class, anybody in the world that is executing a similar process, the best in their own industry, and typically they will also show where they stand relative to industry average. But the key here is that compared to industry average are not impressive. Okay, if you really are trying to drive improvement in your organization, then you're going to in looking at your results, you are going to be careful about believing there are trends, okay, and always know where you stand relative to best in class. Okay, I'm going to go ahead and stop there 1 minute early. I'm happy to take any questions that you all have, including skeptical and difficult ones. I've been at this for a long time. It's not easy to do these things, and And so anyway, I'll hand it off to you all.
Thank you, Professor Easton. Great talk, and I'm sure people will be voicing their comments about this. Who wants to start?
Look at me. Question for you. So one, you briefly mentioned the word mature organizations at the beginning, and that was one of our last lectures. I'm getting the impression just from even being competitive in this, you have to have a mature organization. That's going to be the first step to get there. You're not going to get to this with a fairly immature group.
Well, can you tell me a little bit more about what you mean about get to this? What is this exactly?
Well, I mean, you're talking about implementation, you're talking about measurement, you're talking about cascading down or cascading up, consistency you mentioned, and mature organizations have those processes already in place for communication and measurement and ensuring consistency, whereas organizations that are groups of independent practitioners, so to speak, not coordinating their efforts are going to have a harder time being systematically consistent.
Yes, without a doubt, you're 100% right. And while I was unable to attend Andrew Downer's talk, I see he's on last time. I know his stuff, and it is great. Okay, and I know you all had a wonderful talk. The reality is that most of the organizations, as Andrew would have said, are in the first levels of this maturity matrix. So processes are either not well defined and haphazard, or they are just beginning to have sort of the structure. And one of the great things about Andrew's stuff is he's taken this basic idea of the maturity model and then broken it out into what does this maturity model mean for teams? What does this mean for individuals? What does it mean for communications? And it's great stuff. I know you guys had that last week, but I wouldn't conclude that you can't make progress until you're a mature organization, even on something like the goals of implementation science. Okay, and where you start with this always is asking the question: Is this done in this organization? Okay, so the question would be: are innovations in a healthcare organization? Let's take a specific one. My experience is with Emory Healthcare, but so that's the one that's in my mind. But is this organization moving innovations into practice? Now, they may be doing it very, very badly, okay? But chances are something along those lines is happening, okay? I have reason to believe in healthcare that physicians and others attending congresses is supposed to sort of organically cause them to want to implement improvements, okay? And while that might happen, that's extremely ad hoc. But where you start is to ask, how is the work done currently? Okay. If it isn't done at all and you want to start implementing, then you go look at how somebody else is doing it, and which is benchmarking, and then you try to design a process around that. If the work is being done, then you can begin to structure various steps. Okay, and you can implement metrics. Metrics are very powerful. If there are good measurements, oftentimes that causes changes in organizational behavior. But if you can identify pinch points, areas where in this work that's occurring in an ad hoc way, there's clearly a relationship between a particular step or set of activities and a problem like customer dissatisfaction, then that's where you start. You start with the pinch point because it ain't working. Okay, and so you can use that as an opportunity to put some structure in. So I don't know if I answered your question. Most of us don't have the luxury of being in a mature organization. In fact, very few people.
Is there,
go ahead.
Is there a tension between rapid cycle times
and developing good evidence, particularly maybe thinking in the context of diseases or medical chronology, which may force you into a longer timeline to know what the outcome of a disease or treatment is?
Okay, that is a great question, and what I'm hearing is the intent behind it is absolutely correct. One of the things that makes improvement difficult is when there is a very long time between the intervention and the effect. Okay, and so if that gets long enough, it becomes very, very difficult to do systematic improvement. And a related problem is if there are very, very few data points. Okay, if that's the case, the strategies for trying to attack that are to understand what the causal variables are and then manage those, which oftentimes you can do in a faster way. So the basic idea is that I understand that there's a correlation between this ultimate outcome measure and some upstream measure, and now I'm going to manage that upstream measure, hoping that it has the effect on the outcome measure, and that I'll eventually be able to see that. But yeah, if you can't get data in a reasonable amount of time, it's hard. You have to be driven by theory. So there's no magic bullet on that one.
I have a question and a comment. The comment would be a lot of healthcare quality control or quality management processes nowadays focus a lot on the processes and less so on the outcomes. This is a frequent criticism of the quality improvement systems that healthcare organizations apply. And it's fascinating how even the reimbursement starts being tied to that. So funding agencies, payers, look at the same thing, that what processes you have, and less so at outcomes, or if they do look at the outcomes, those are very raw and very kind of undifferentiated outcomes that are sometimes either overlooked or would be important to be a little bit more refined. What are your comments about that?
I would agree with that, but I would make the following comment. One of your former colleagues at Emory, an anesthesiologist by the name of Grant Lindy, I've had a lot of interaction with, and he maintains that it's extremely important to use these process measures because the outcome measures, it's typically very ambiguous who's really responsible for them. In other words, the final outcome measure is a function of a lot of different things. Okay, and he gives some examples from Emory Healthcare. So again, these are complex and difficult questions, but at the level of managing the process locally, you need metrics that you can get, which include, did you conform to the process? A standard sort of answer to that would be that it is management's job to make sure that the upstream measures, like these process measures, correlate with the outcomes. Okay, so I guess another thing that comes to my mind is that you want the metrics at the level of the work process to be actionable. That's another thing. And of course, you need to have, criteria in place for how to act, but ideally they're going to be actionable, and there's not going to be so much random noise in them that it's very hard to see the actual effect for the noise. So I don't know if that answered your.
No, it did. Yes. The question relates to the fact that when you talk about structure and processes that you have in place, The unspoken concept there is the standardization, and to what extent you can find a good balance between the extremes of top-down standardized processes that work for everybody, versus, which is kind of the example would be that the total quality management, to the Lean Six Sigma other end of the spectrum, where small teamlets produce improvement and then they deploy the innovation at a smaller scale. Because one of the current threats in healthcare is burnout, professional burnout. And one of the major drivers has been identified the distance of the healthcare professional from those who design the strategy, the processes, or the standardization process per se, and the lack of involvement of the frontline workers.
Okay, so let me. That's a great question, and it's also a rich question. So let me just respond to it in a variety of ways here. The first thing is that somebody has to make a decision, and this is true in any business. Suppose as to whether or not you're going to enforce the same process on everybody, every unit. Okay, or whether you're going to allow them to develop their own process. And there are arguments for and against each one of those. However, in either case, you need to be trying to get to the same level of rigor. Okay, and by rigor, I mean how well defined is the process, how well measured is it, how is it correlated with the customer satisfaction and outcomes. So when I look at an organization, I generally accept their view of whether it's better to have one process that's driven everywhere or to allow different areas to develop their processes. What I don't accept in the latter case is that there's a lack of rigor. Okay, that you should be moving towards that. Now, the problem with the external processes is work groups, if a process is imposed on them and they have no participation in developing it, they're very likely to reject it. Okay, so one of the positives of allowing various areas to develop their own processes with somebody enforcing the rigor level is they then own it. It's theirs. Disadvantages are if you're doing things in different ways in different places, you get more variability. So there's not a clear answer there, but the one thing that is clear is that you're moving towards rigor. Okay, I mean, that's my opinion on this.
Right, the meta process that regulates the processes.
Yeah. Yes, and I will tell you that I do believe that frontline, employee involvement in process design and improvement is absolutely critical. I mean, people just hate it when some know-it-all from the outside comes in and tries to impose this stuff on it, and that has failed so much. ISO 9000. Development was an example of that. They hired all these consultants, typical companies. They came in and documented the processes and then told people what to do, and people never did it. So that's a great question, because you've identified a real tension. I think you can get to the same place both ways, as long as you don't forget that what you are looking for is this level of rigor.
I don't see any questions in the chat. Anybody online wants to add any comments or pose a question?
So one last question, does technology help because you can constrain the process with the technology, but also measure it at the same time?
So the answer is technology certainly can help a lot. It also can hurt. Automated measurement absolutely is a good thing, because otherwise measurement is oftentimes too hard to do. Technology can be used to actually impose sort of a framework in a way that's positive. It can also introduce constraints which are not helpful and are resisted. So Emory has recently changed the electronic medical records, and last time I was talking to various MDs about it, they absolutely hated it. And so it was becoming a game of how were they able to do what they wanted to, when they had to check all of these boxes. So you have to be very careful. I mean, the history of failures of technology systems is long, going back to ERP systems in the 1990s. And I haven't been tracking what's been going on with the electronic medical records, but I suspect there may be a lot of issues there.
I guess it depends on your outcome measure, right? If your outcome measure is satisfaction with the system, you're gonna have a poor result. But if your outcome measure is 100% adoption of the system, if they have no other choice, you've made your point.
Improvement in billing collection.
Right.
Except people figure out ways to get around it, right? I mean, that's that becomes a problem. You do. I'll tell you, and I tell my students that consensus and buy-in are huge in organizations. And so, kind of what I say to them in a little bit of a flippant way, if a project takes 3 days to do, but 3 months to get consensus, it takes 3 months and 3 days. My sense is that certainly at Emory Healthcare, there's a lack of consensus about the new EMR system. I'll put it that way, politely. Okay, now whether this crashes and burns or whether the people adapt, I don't know what the outcome will be, but it's a problem, and there are other problems as well around it. So, I will shut up here shortly, but I just walked into one of the doctors, and he wants to record the entire system because AI is going to write his notes. Well, I'm sorry, I don't want my conversation with my doctor recorded. So, no consensus on my part.
Well, thank you so much, Professor Easton. This was great. Thank you for participating again and bringing a great new perspective on our implementation science for innovation and discovery series. Thank you all and have a nice evening.
Yeah, and thank you very much for inviting me. I've enjoyed it, and I always enjoy the questions you all ask.
Thank you. Have a good night.